So our next session, and we actually talked about in the previous session a little bit, is looks at remote patient monitoring and AI enhanced care beyond the hospital walls. This conversation features Dr. Trini Truong, the Chief Medical Officer of Mount Sinai at Home and Associate Professor of Medicine at the Icahn School of Medicine at Mount Sinai, where she leads the expansion of innovative home-based care programs, including acute hospital at home, rehabilitation, palliative care, community paramedicine, and home infusion services. The talk will be moderated by Dr. Kamal Bashash, Chief Quality Officer at NYC Health and Hospitals, Jacobi NCB, and Medical Director of Sustainability for NYC Health and Hospitals. She is also a professor of obstetrics and gynecology, the women's health at Albert Einstein College of Medicine, and she's recognized for her leadership in simulation-based training, diagnostic excellence, and sustainable healthcare delivery. Thank you both. I'm going to stop my sharing and I'll turn it over to you two lovely ladies.
Thank you so much, Carol. Really, what an honor to be here with all of you today. And it's really my privilege to be able to be in conversation with you, Dr. Truong. I've been a big fan of your work and, we're neighbors. And so just delighted to be able to explore, hospital at home with you in a more granular way. And so, there's a lot that has been written about the program that you have built. And for those that haven't had a chance to read, please seek it out. But I'm wondering if you could provide a little bit of an overview of what Mount Sinai at Home is.
Yes, yes. Well, thank you so much for the introduction, the kind introduction, and thank you so much for inviting me to this panel. It's really, truly a privilege to talk to this esteemed panel here, and thank you, Dr. Baja, for talking with me. So a bit about hospital at home. I'm just going to go back a little bit. I know that many of our attendees are aware of hospital at home, but for those who are not, I'm going to take just 10 seconds to go over the history a little bit about hospital at home. So as you know, hospital at home is a care delivery model that delivers inpatient level care in the patient's home, in the comfort of patient's home. It is inpatient care substitution, is not post-acute care, is not OPAD, is not home care, but is true inpatient care. This model of care is not new in the world. Internationally, it existed maybe in the 70s in the UK, and then in Spain, Australia, and a few other places as well. In the United States, this model of care started back in the late 90s, and then Dr. Bruce Leff at Johns Hopkins did the first randomized controlled trial on this to demonstrate feasibility and efficacy of this model. And then now is the story of Sinai. So back in 2014, Sinai, our esteemed geriatric colleagues had a big grant to study hospital at home in a bigger scale. And again, they demonstrate that this model of care delivers high quality and patient-centric care in the patient's home. Then for us, where we started this model in a continuum of at-home care. So we start with hospital at home, but we also have other models of care within this continuum as well. We have the rehab at home care, we have palliative care and home care as well. So right now we're in operation. We operate the model under the individual contract-based, value-based care. And then in 2020, as you know, COVID happened and everybody was hoping for inpatient bed. So overnight, CMS with folks at Sinai and some other places in the country, overnight really created this acute care waiver that allows hospital that taking care of, certified to take care of Medicare patients to apply for this in order to provide inpatient level care in the home. And we've been operated ever since then in this model, in addition to the value-based care.
Amazing. Thank you so much. I actually didn't realize that the program had been in place since 2014. So I can imagine it's been quite an evolution. And I'm glad you mentioned the CMS waiver and some of the new models of reimbursement for this work. And we're going to dive into that in a little bit. But I have to say, I'm a chief quality officer, right? I'm a data nerd, a measurement nerd. There's a lot of sort of folks who've been talking about, outcomes and metrics throughout the whole afternoon. And so, I'm wondering, as the program has evolved and where you are now, what are some of the measures or outcomes of success that you are tracking? Because, at the end of the day, we treasure what we measure.
Yeah, yes. Definitely. The when you say evolution is truly applicable to hospital at home, because the program that we had during the grant phase, which was 2014, 2018, is quite different from the program we had before the pandemic, and is quite different from what we had in 2022, and also very different from what we have right now. I joke that hospital at home, starting a hospital at home program is like a startup. It is truly a startup operation, and we evolve and innovate, and even the metrics that we track evolve over time as well as we become more comfortable and more advanced in this space. Um, so from the first original studies, we always compared to ourselves to the alternative. The alternative is that staying in the brick and mortar hospital. What do you track? What matters most to patients? Quality, safety, length of stay, readmission, ED utilization, and mortality. And all of that was shown in the study as well as in real life, reported by CMS as well recently in 2024, is that everything was at least the same or better than brick and mortar hospital. But one thing I would have to call out is that patient satisfaction, the Press-Ganey equivalent of this, is that how likely you recommend hospital at home. The same question that we have for the hospital is that everybody, like majority of people who've gone through this, love this program. So it is truly patient-centered care.
Thank you so much for that. I think it's really important that no matter where, what role you play within digital technology and technology in general, looking at sort of those, like you mentioned, some of the things that are existing measures, CMS star, Leapfrog, HEDIS score, patient experience. These are things that are every institution, no matter large or small, will track. And to your point, these measures will continue to evolve, which is exciting, right? Because they need to be as patient-centered as possible. So thank you for that. Can you tell us a little bit about, how do, New York is a very diverse place. And you mentioned, patients are at the center of the program. Tell us a little bit about, how did you ensure that you designed the program to meet the needs of all kinds of individuals? And can you give us a really granular success or measurable impact?
Yes, and thank you for asking me that question. Because I would say that not right now. I think people are a bit more aware right now, but I think before, when we mentioned hospital at home, there's a lot of misconception that in New York, I'm talking about the New York population, New York folks here. They think that this is a model, concierge model of care for the Upper East Siders and Upper West Siders. But in fact, we do have our own data from study as well as in real life to demonstrate that we serve the same population that are in our neighborhood. And our neighborhoods around here are quite diverse. And just to backtrack a little bit, so we know from study, and in reality, hospital at home provides high quality patient-centered care. The patient love this care. It's really great. And we also demonstrate that everybody benefits from this model of care. But beyond that, the folks who benefited most from this model of care are the folks who are in the lower social economic status, indicated by zip code, indicated by a Medicaid eligibility. So those are some of the studies that we did. And then we want to make sure part of the metrics that you mentioned earlier is that our metrics also evolved. So initially we track length of stay, readmission, all of those, but now we also are integrating some of the evolving metrics to track our outcomes to measure that we are in fact serving a diverse population. And so we track who are our patients? What percent of our patients are certain demographic? So what certain population who prefer a language other than English? Patients who need home health aid, like caregiver in the home. Patients who do not have, who need food support, food insecurity. So these are the metrics that we do track. And we're lucky one of our medical students actually just published a research letter in this as well.
Thank you for that. I think that's a really, really important lesson for all, as you're thinking about the programs that you're deploying, what are some of the structural or social determinants of health that you need to be looking at on the regular to make sure that you're meeting the needs of all populations? Trini, do you mind giving us a very granular success? Like what's something that, like a story, a patient story, a program that you're like, it's something that everyone's like, wow, we did that.
Yeah. I think I have so many of those stories, and I would start. I'm a mom, so I would say first, it comes to my mind first is when you just deliver a baby, all you want is to be with the baby. Now, you unfortunately have a UTI post-delivery, and you can't go home. Your vital signs are not stable. You have AKI. You need all these things. So therefore, our hospital at home were able to take care of the mom in the home so that she could be with her newborn baby. Or other stories, recently there's a patient who, a typical story is this, a patient who's elderly came to the hospital for CHF exacerbation, stay in the ED. Our EDs are always very full, so stay for a while. Usually they'll stay and they have all sorts of risk of inpatient delirium, inpatient hospital-acquired conditions. Then they can't eat the food they want. They can't have friends who are visiting them. They're stuck in the ED overnight. They might have risk of falls. And then we take them home. They're able to be around family, and also being able to around friends. And she, one of our patients, attended virtual church with her friends in the home. And we were able to see what she actually eats in the home to facilitate the care plan for her to improve her long-term chronic CHF exacerbation. And
I
I'll tell
love,
you another story.
yeah,
This
please.
story, if you ask me, I think you opened the Pandora box here. And we also track these systematically using Press-Skinny questions, but also qualitative tracking as well. So we also have a patient who she has diabetes. She's been in and out of the hospital multiple times, and they can't really figure out why she was so hyperglycemic or hypoglycemic. And I living in New York and also being hospitalist, we see this a lot. And when we discharge as a hospitalist, they go home and we're like, okay, this is your regimen. Go and get your medication from CVS and everything is good. So we admitted this lady, and in the hospital, we were told that the patient was on one regimen of Lantus. We went home and we found, lo and behold, under her bed, there's another set of insulin with instruction that she's supposed to take. Then she also told us that actually I don't take what was told me. I take this a different regimen. And then we went on her Epic and review her outpatient chart. She's on a completely different regimen. So we were able to work with her diet and being in the home and throw away what medications that she's not supposed to take, and improve her care. So I would happily report that her readmission rate has really improved since then.
Thank you for those examples and really inspiring. And what I really appreciate is, a young mom who just delivers who has a urinary tract infection and needs antibiotics, right? Someone with a chronic disease, a chronic heart condition that then needs regular care. And then, polypharmacy and dealing with medications is a ubiquitous challenge. And clearly, health at home, hospital at home has that opportunity, as you said, to really sort of serve as that 360. I want to zoom in a little bit on first the technology components, and then also the human components. In the prior panel, someone said, I wish the technology was the leading thing, and actually it's the humans, right? And so, and I want to spotlight a question that's in the chat. Thank you, Joe. And so, could you share a little bit about some of the technology infrastructure, including some of the AI-based tools? And then Joe, asked a question about, the remote monitoring data, and have you partnered with other organizations such as Best Buy, Current Health, et cetera, to sort of bring together this remote monitoring data? So could you talk a little bit about the technology ecosystem that it takes to get this done?
Yes, thank you for that question. I'm going to start to say that hospital at home has vast opportunities for technology in general, any technology in general, and AI in specific. And there are a few reasons for this, and many reasons for this, but I would just name a few. One is that this is a matter of this is decentralized care. So we don't have the luxury of your care team being spatially together to coordinate the care. My coordinator who going to get the medication from the pharmacy lives in Nashville, and they may be in a different time zone. And our nurse are now traveling to lower Brooklyn. And then I'm here on the Upper East Side, and the patient is somewhere in Queens. So how, and pharmacy, not even think about pharmacy at this point. When I'm a hospitalist, when I'm in the hospital, I place an order, and within an hour, maid and medication go to the patient's bedside, and the nurse is right there and they can deliver. But when I'm on hospital at home, all of that, there's a built-in time and there's a built-in need for communication with these. And I think the previous panel already touched on this. Communication is one area where technology can have significant impact. Two is that hospital at home, as opposed to home care or chronic care management, we are higher on acuity. So imagine, these are the same patients you see in the hospital. We need to be able to communicate and deliver care timely and not wait for a dashboard to come out. We can't wait for an email to come out. It needs to be instantaneous. And right now, without technology, it's very difficult to achieve that. And thirdly, there's a lot of operation aspects in hospital at home, from patient selection to patient care to monitoring of the patients in the home, that really requires technology to be integrated into that.
Yeah, sorry, go ahead.
No, go ahead.
So, I really appreciate that. And, there's a lot of moving parts in a hospital, and certainly similarly for hospital at home. A health system cannot do everything itself. And so I'm wondering about some of the partnerships that Sinai has forged in order to be able to do this work. Could you talk a little bit about that?
Yes. So we do have a technology partner. So one from in-hospital at home for patient selection is one of the key issue to make it successful. And everybody in this space is very acutely preoccupied by this. So we use the technology to help us select the right patient. And then we design this with natural language processing. Then we use machine learning to really fine-tune that algorithm. And for patient care in the home, we also use a different technology to monitor the patient in the home. And we found that we, talked to and worked through a few different ones, and we settle on one that does serve the purpose, and also that it does have the ability, and it has integrated AI algorithm to help us be more efficient as well.
Thanks for unpacking that a little bit. As someone who is a healthcare leader in this space, it has been interesting to see the quick evolution of some of these technologies that you mentioned, from selection to service to monitoring to then, like you said, sort of looking in the fridge, right, if you will, and helping patients understand, sort of their care. And looking at sort of the ecosystem, there is such opportunity here, as you mentioned. There's a lot that's ripe for innovation to really hit the mark for patients. Can you talk about a little bit about the human side? And I first want to start by asking you about you, right? How did you get into this work? And then I would love to talk a little bit more about, how you train individuals, how you, talk to patients about this. But first, what about you? Tell us a little bit about your story.
I began my career in the patient safety and innovation space, and I loved it. And I did a lot of patient safety and quality for the hospital department. But then when this opportunity came up, you always talk about, my resident and medical student always ask me, how do you get into it? And sometimes opportunities fall into you. And then I quickly accepted this position because of a few things. I think that I always ask myself this question: how many times in my entire life as a clinician do I get to do something so transformative? I think that's not many. Maybe this is it for me. Maybe this is the area where I could have the most change, and truly we are together transforming the way we deliver care, the way the health system, and that is being transformed for patients and also for us. And patients, there are many reasons why people would love to be on hospital at home. One is patient quality, safety, being in the home, and then especially patients with certain populations. So patients who have certain religions, patients who have certain dietary restrictions, or patient who speaks a certain language, they prefer to be in an environment in which they can control all those factors for their care. Or patients who just prefer to be home.
Mm-hmm.
And then that's why they love all of that. We provide more holistic care to patients. And I want to talk a bit about why providers love it, because it's innovative. Like you don't get more innovative than hospital at home. And two is that hospital at home also affords us the ability to do remote work. And I think the flexibility in work is one of those that our docs love it. And two, we love, I go to medical school, and I envision myself being a doctor and really knowing my patient, taking care of my patients from a holistic way, like you having a holistic approach to care. And here I am. I worry that I don't have that on other side as an inpatient, isolated, episodic care. But now I am here. I see them in the hospital and then go home, and I could communicate and connect them with the outpatient.
Thank you for that. I mean, your passion for this work just sort of comes through the screen. So thank you for that. What you said about, being able to think differently at sort of different intersections in this inaugural role really resonates with me. I serve in two sort of inaugural roles as a quality officer, and also thinking about waste reduction in healthcare. And it's to your point, it brings a lot of joy to be able to connect all of those dots. So, there is no doubt, you mentioned patients. There's a lot of great reasons why patients love hospital at home. There's a lot of great reasons why the healthcare workforce likes hospital at home, but technology can be a scary thing, right? For some folks. And so I'm wondering if we could zoom in a little bit about, how do you get your doctors, nurses, pharmacists, et cetera, up to speed on the technology? And then similarly for the patients, how do you get them up to speed, in order to be able to engage in the hospital at home?
Yeah, I think that is where change management comes from, and it just iterate works. And let's talk about the clinician and the nurses side. There's something about the folks who gravitate toward this model of care, where they are more of the early adopters. So they're willing and are agile and are flexible and are willing to learn these new things. And we love those new things. And then two, and from the patient side, I would say that, we set up the technologies in patients' home, but we teach them constantly. However, we also provide a safeguard, a fallback system if they are unable to do certain things. What are our strategies to address that?
Mm-hmm.
And thank God, I think so far it's been working out well. And it seems like more and more patients are liking it more and want to be involved in it more.
Yeah, thanks for that. Can you give an example of one of those safeguard strategies, or a story about sort of, because people have all different kinds of technology literacy. What are some of the strategies?
Yes, yes. Part of the screening for patients to hospital at home is that one, they have to have a phone. It doesn't have what kind of phone. They have to be able to dial phone. And if they can't dial the phone, some of our patients can't use the phone, and we want to make sure that they have someone in the home, or we set up a caregiver. We could provide up to 24-hour a day of caregiver for patients who need it in the home who can do that for us. So, but then for our care system, we set up a portal where patient can just click one click and then go Zoom to us and go to us. But if they are unable to do that, then they could just always call us.
Got it.
Yeah.
Yeah, I think it's really important to consider all of those options, right? And so thank you for building out that system. I love that Deb just messaged, and it's almost like she was reading our minds when she asked, "Can you talk about reimbursement?" Right? Because at the end of the day, the stories that you shared are so inspiring. The journey has been inspiring, but it all comes down to great patient care that is of high value, right? And dollars and cents. So can you talk a little bit about, obviously 2020 rev the engine. Can you talk a little bit about some of the discussions you had at that time to get things going? And then, what are some of the discussions that you're having now? How is Mount Sinai structured to really capture revenue, right? Both in the fee-for-service models as well as in the value-based care models. I think it's a really interesting evolving landscape.
Yeah. It's funny that this model of care, because of the way that we structure inpatient care in the United States, makes it difficult for us to have a flourishing model like other parts of the world. We had Israel, the delegation for Ministry of Health from Israel came over, and what they have is capitation and they have, value-based care. So this is no brainer for them. But for us, it took a long while. So for the value base, just very basic, simple way to explain this is prior to the waiver, what we had was we individually had to negotiate with individual payer for our ability to take care of their patients. So let's say, you pay the hospital an X amount, taking care of the patient during the acute phase. Then we say that we come in and say, okay, why don't you pay us that amount? Some places do some discount, some places don't do a discount, and some places also do a little extra and say, now I not only own your patients for the acute phase, but with the whole 30-day. So value-based care in this in this model. But as you can see, the operation of that kind of payment for a model to grow is very difficult. Because right now, for patient selection and scale of your program, you have to start with a big funnel, but then go down lower, much lower. So that's why a lot of programs didn't really succeed early on. Then comes the fee-for-service and the CMS waiver that now allows us to be able to take care of pay fee-for-service patients, but at the same time, the commercial patients as well, because of the waiver. They sort of set the precedent for the other payers. So now we can be, and many programs are insurance agnostic, where they take patients regardless of insurance and reimburse as DRG for those patients.
Yeah, thank you for that. I know for certain there's a lot of government relation teams who are active in this space. I believe that you have also, in your various leadership roles. Can you talk a little bit about some of the advocacy that is ongoing at the city, state, and federal level?
Yes. So hospital at home is, let's talk about the federal level first. I think, as you all know, in this space, our waiver is set to expire by the 30th of this month. So there's a lot, we're waiting for a lot there. And what that means is that the implication is that if it's not extended, we must send our patients back to the hospital who are not value-based. And we don't want to do that. So most likely for the majority of the people in this space, they know this is a model of care that is supported by both sides of the aisle. So we know and then it's budget neutral. So there's a high chance that we pass. And in the latest version, it is set to extend for 5 years. However, because of the political climate right now, I think is a bit unstable. So we want to make sure that it would not have a gap, even a small gap during this time of debate on both sides. There's a lot of organizations that are advocating for this nationwide, AHA, the HA user group. We do a lot of advocacy. And if any of you are interested in doing that, please let me know. And I think that is those are important venues to do. And there's many more as well. From the state level, especially in the New York State, the support is there, but it has yet to be approved, the model itself. However, we are operating as usual. It's just not approved specifically for hospital at home. And we are, the people here in, some folks from the programs here, in New York City at least, and around the area, we are forming a small consortium to be able to work together, improve, and also provide more advocacy as well.
Thank you for that. I'm going to invite the group. We're going to switch to Q&A in a few moments. And so, Dan, I see your question. We'll get to that for sure. I'm curious if you could, we talked a little bit about models of care. We talked a little bit about advocacy in sort of constrained environment where CEOs and CFOs, are making decisions perhaps in ways that, it's always been constrained, but it may, as you said, different ways. What are some of the metrics that you're going to be looking for that are most persuasive sort of going forward, right, to keep these programs going? And that kind of leads me into a little bit of thought on, what do you think the future of hospital at home looks like?
The metric at the immediacy of the metrics that I would say C-suite, the boards would want to know are of a few. One, everybody wants good patient care and patient outcomes and patient satisfaction. I think that's a given. And we all know this and we all understand that. But at least for organizations or health system with inpatient bed capacity issue, this is the number one reason, the number one motivator for us to create a program like this. So because it you can save your beds for higher acuity patients. So not just 1-for-1, but the beds, the inpatient beds that you're using for the higher acuity, the more complex, the higher value patients. And at the same time, you're decreasing the ED boarding time, which we know is poor indicator of health for the ones who go into hospital home and also the one who are staying in the hospital for the brick and mortar. Mm-hmm. And the other one I would say, and I would say is that in this very competitive world of healthcare, there's another reasons why we want this, is that it's a competitive differentiator. Our physicians are world-class physicians, surgeons, who can now say, instead of you from Dubai, fly here, and we provide your heart valve surgery for you. And now we could also say that you could come here, and if you want to stay in the hotel, we could also provide that for you as well. So the competitive differentiator for a lot of places. And also, this is an innovative world, like innovative space, where at least for me and the people in this space, we believe that hospitals in the next, I would say 5 to 10 years, are only for places where people need surgeries and people who are very, very acutely ill. The rest, we can take care on hospital at home. And we have. We started out with typical general medicine type of patients, pneumonia, sepsis, COPD, CHF. But now we are advancing into taking care of oncology patients, cardiovascular patients, ENT patients, OB patients, pediatrics patients. These are the populations that can already been cared for by hospital at home. So, but then a lot of it is depending on the payment model as well. And I hope that, we would have, after this long waiver of 5 years, we'll be able to have a more permanent model of payment so that we can really innovate and be comfortable about making the investment that we need to start a program like this.
Yeah, thank you so much for that. So, forecasting into the future, we already alluded to the fact that some of our tools that we use, right, need to continue to iterate and evolve and become better. So Diana spotlighted some challenges specifically with non-inclusive equipment, for example, non-inclusive blood pressure cuffs or oximeters that are less effective in certain complexions. And so I'm wondering, your thoughts on, how do you evaluate these tools and what are you looking for in these tools as you go forward?
Yeah, I think that's an important question to consider, an important aspect of care. We, as an institution, we are committed to provide equitable care and equitable access to care for all patients. And in hospital at home, we always talk about, to scale, we always talk about clinical scalability, increase your clinical capability. But at the same time, in order to be sustainable, we also need to increase our social scalability as well. So taking more socially complex patients to hospital at home. But what that also means is that we need to be able to develop technologies and tools that we can provide the care that they need in the home, safely in the home. And absolutely, the conversation about the inclusive technologies for patients, that is essential. And I think that as we take more socially complex patients, those are the tools that will be very needed. And we need to track metrics for this, right? We talk about, to start out, we talk about the type of data that we keep. And we don't know what we need, and we don't know what our patients need if we don't really talk about who we serve. We don't look at who we serve and ask the questions that we need. So I think first is looking at who you're serving and what our patients need.
Thank you for that. Given my background, that I couldn't resonate with that more. So there's an anonymous question that came in. You sort of mentioned what are our needs and, how can we serve them? And that speaks a little bit to governance and structure. And so I was wondering, how does your program hook into kind of the infrastructure of governance at Mount Sinai? And the question is, do you believe that hospitals or health systems should eventually have a dedicated AI department, right? Just like we have a Department of Medicine, a Department of Radiology, a Department of whatever. So first, if you could talk a little bit about the governance that currently exists, and what do you see kind of in the future? Is there a separate AI department? What do you think?
That's not my specialty, but I would venture to say I'm a bit biased because at Sinai, we do have this department. We have an institute for this. And we constantly are working in different aspects of care. And in fact, I help working with our clinical data science team to develop some clinical support tools for our admitted patients. So I believe that tech and AI are really essential to healthcare right now. Not in the future, right now. I think in order to be sustainable, healthy workforce, efficient, and financially sustainable, we need to integrate AI and we need to integrate technology into our into healthcare. But we have to do it in a way that is feasible as well. I'm talking about for a clinician. When we integrate AI into care, it is not the tool itself. And I think the other panelists already mentioned that. It is not the tool. I mean, it's not just the tool. The tool is great. There's so many great tools out there. What is most important is the implementation phase of the tool. How we implement that. It really comes down to change management. How to integrate that into your workflow and make it sustainable. And I learned this from personal failure of instituting or implementing a tool into the inpatient care.
Thanks for that.
Expensive lesson.
Yeah. Well, and I think that certainly our organization and others, to your point, have sort of developed a center, sort of an innovative hub within a large ecosystem. But the sauce with those is as they're being built, they hook into all of the sort of other existing sort of clinical departments and areas. There's representation there. And that's really, I think, to your point, just as at Sinai, where you get the sort of most value out of those. Where does hospital at home report into now?
Hospital home in the country, they are set up differently.
Yeah,
It may set up differently at different hospital, a different institution. For us, is right now is a joint venture with another program. So we are operating as its own lone-standing joint venture that is part ownership by both sides. But for quality safety, we are reporting under the hospital umbrella.
Got it.
Other programs, they're part of the hospital, yes.
Are you able to speak to what that other partner is?
There are many different partners, and there are, we are with Contessa. It's Contessa Health and Medicines. There are also other ones as well, Medically Home. We have a few other ones as well.
I gotcha. Perfect. Thank you for that. So, we have just a few minutes remaining. I don't see any other questions in the chat. And so, I always think about, wow, if I had a magic wand, or if we, right, the people on this, the hundreds of people who are on this or who will see this later, right, if you had a magic wand, right, because I think so many of us, all of us really want the best healthcare for ourselves, our families, our communities, our, who we serve, right? And so if you had a magic wand, what would you like to see as it relates to hospital at home?
One is payment model. If you ask me, we need a permanent payment model of this. And two is that please develop technologies that we can use in hospital at home. Is this continuum from the patient selection, patient home, patient care delivery, and then discharge care, like coordination of care. All of that in itself, like the whole journey of the patient, there are plethora of opportunities for AI and technologies. Doesn't have to be AI. Any sort of tech can really fill those gaps.
Love that. I mean, you've heard it here, right? So payment models, right? No matter where you sit, right? Think about payment models, think about innovation. I couldn't agree with you more. There's still a lot that is like remains to be seen, right? And can be done in this space. I think for me, along that similar lines, one of the things that I've been thinking about, and you alluded to it earlier, right? You went to the patient's home and you saw that she had like all these different kinds of insulins, right? I think this idea that, people interact with health systems 1%, 2% of their lives, but what about the other 98% and how it impacts their health? I think this concept of health at home or hospital at home, to me, as technology evolves, I would love to be able to, do things where it's, you're able to make a full assessment of how people's lives are day to day and how they impact their health. And I think what you said, right? 5 to 10 years, it's not that down the line that we will start to see some of those things really come to reality. Right. So with that said, I can't believe that 45 minutes really has come and gone. Thank you so much to the audience for your attention and engagement. And really, Dr. Truong, thank you for your expertise and really paving the way in this space. A delight to be in conversation with you.